for your towel. All right, my friends, today I'm going to talk about a relatively simple, but somewhat complicated case of the missed STEMI. And I want to give you a spoiler alert. I don't have that much information to share on the patient because actually, based on the excellent care that he received, the early diagnosis, the rapid intervention, the patient only stayed with us for a day, which is pretty amazing. He was discharged from the cardiovascular intensive care unit. So really great work done by all, especially when we take a look at the information of our patient. So by the way, case of the missed STEMI, any one of us would have missed it. Probably most of our attending physicians would have missed it. Really gives a case for actually shifting over to cardiology when you have some questions about how a patient is presenting. So I like to remind you, when we talk about diagnosing somebody who's having an acute coronary event, and in particular STEMI, which means full wall thickness, lots of electrical current changes, those tend to go to the front of the line. Those are the patients who go to the cath lab really quickly. We basically have four, maybe we can say five, four basic presentations. Number one, the patient history. Number two, the patient's presentation by EKG, not necessarily saying, is he diaphoretic, is he vomiting, is his pain from front to back or up into the jaw or radiating down the arm. That's really part of the patient history. Presentation is, does the EKG look like or seem like a STEMI? And historically, when we talk about STEMI, we talk about ST segment elevation in the limb leads of at least 1 millimeter in 2 contiguous leads. Now that's important. 1 millimeter in 2 contiguous leads. That means 2 leads of a lead group looking at a surface area. For limb leads, it only needs to be 1 millimeter. For chest leads, it needs to be 2 millimeters. So we're looking for ST elevation. That means up from the baseline, 1 millimeter in 2 leads contiguous of the limb leads, 2 millimeters in 2 contiguous leads of the chest leads. In general, when we see changes in one lead only or changes in all leads, that makes us think something other than STEMI. So important to remember that when I have enough electrical current on one side of the heart to cause ST segment elevation, when I'm looking from the opposite side of the heart, what I'm going to see is opposite changes, meaning ST segment elevation on one side of the heart will be represented by ST depression on the other side of the heart. And then in addition to that, so that's the third thing, patient history, presentation, looking like a STEMI with reciprocal changes if you have reciprocal leads, and then ultimately on evaluation of cardiac biomarkers. So we know that as you infarct your cardiac cells, they lyse and they spill troponin into the blood. And that's going to be a really important component. A lot of us are using standard troponin. Normal standard troponin is 0.04. But what that means is anybody under that 0.04 who may actually be lysing their cells will not be recognized until they're greater than 0.04, which is why we now, most of us, I hope, are using what we call high sensitivity troponin. It's the exact same troponin measure, but it's times 1,000 because it's measured in mils rather than in liters. So really important to say 1,000 times 40 or 1,000 times 0.04 would equal 40. Okay. Now, below that number in a high sensitivity troponin, below that number indicates an acute coronary syndrome event, which is why we use high sensitivity troponin, because that little narrow window underneath that 0.04 tradition, 40 in high sensitivity, that window of 20 to 40 in a man or 15 to 40 in a woman, which would not be identified by your standard troponin, actually tells us that we have a patient who's lysing their cardiac tissue. Now, it may be they have a chronic syndrome, they may have other syndromes, it may not be necessarily that the patient is having a STEMI. But anytime we see in a female a troponin higher than 15 or a man a troponin higher than 20, who has a process that we think is acute, we'll always follow that with a second troponin 60 minutes later That second troponin, if it's still continuing to rise, and that means a delta of 5, it has to increase by 5. If you have an increase of 5 in that second troponin, you've got an acute event. Now, that's going to be really important. We want your history to be positive. We want your EKG presentation to be positive. We'd like to see reciprocal changes if applicable. That's number 3. And then number 4, we want to see that you have an elevated high sensitivity troponin. Now, I want to review those criteria because now we're going to apply them to our patient. Okay, our patient comes to our hospital on 6/11/2023, so really just a week or so ago, at 22:13, in through a very busy triage. And triage, the chief complaint that the patient is bringing to us is, I've got intermittent mid-sternal chest pain. It radiates to my left arm and neck, and I've had it for 2 weeks. Ding, ding, ding. Right away, perspective is, this can't be STEMI or acute myocardial infarction. He's had the pain for 2 weeks. He states that it gets worse when he's doing physical activity. He describes it as things around the house, but it's actually physical activity. And he says that intermittently he has shortness of breath, fatigue, and dizziness. Now, I, as a triage nurse, would say to this patient, when you have chest discomfort and that radiation of pain, is that when you get more short of breath? Is that when you feel more tired? Is that when you feel dizzy? And they may have asked that, but I don't see that documented. This is what's documented from the triage nurse. And great, this is great. So right away, I think typically we're going to say, our patient has some acute chest pain. We don't really think it's a STEMI because the pain's been going on for 2 weeks, and that's really unusual. That doesn't usually portend towards a STEMI. So 2 weeks, what? Probably not a STEMI. And maybe I've reduced my urgency about evaluating this patient just a tad bit. I may have reduced my urgency about it because he's had 2 weeks of chest pain. But you know what? He's got acute chest pain. So I am going to say what's next is I need to do a STEMI screen EKG. Now, at our hospital, STEMI screen EKG means you're supposed to get an EKG very, very rapidly. Really, while you're in triage, you're going to get a STEMI screen EKG, which is actually going to rule in or rule out whether or not you've got a STEMI. You're going to get a point of care troponin, which is old-fashioned troponin. That's all we have at point of care. But you are also, at the same time, going to get an HS troponin. Now, that point of care troponin, when we look at that, tells us right away if you are greater than 0.04. But remember, we have that little window underneath there from 0.02 actually to 0.04, which is 20 to 40, that we're going to identify with your HS troponin. So that's really important for us to appreciate. We do point of care and we do the HS troponin, and we're going to take a look at your vital signs. Patient's vital signs are really quite stable. Heart rate is stable. Everything else looks pretty normal. We're pretty happy with how the patient looks. And then we get a fuller note. This is the first resident physician who writes a note saying, here's our 63-year-old man who has a past medical history of asthma, diabetes, HIV, hypertension, who presents today with complaint of left shoulder pain, left back pain, left chest pain. He's had that pain for 2 weeks, and he's had it because he was traveling and because he's drinking caffeine drinks. And he noticed that when he wakes up in the morning, he's got this pain in his shoulder. It's left, and it's going down to his left elbow. It's kind of a weird description, right? Patient says he also has this pain along his left chest, describes it as pulling. And he reports that in the morning, he has no pain. Earlier, he said he did have pain, but he continues to work his day, and his pain worsens throughout his day or her day. Patient is a hairdresser, denies fevers, chills, all those types of things, pretty much anything else that we would look at, any long recent travel, anything that might lend itself towards DVT or PE, like malignancy or surgery or any hormone replacement. And he presents to the ED today, not because he thought he should come to the ED, but because his sister is in our sickle cell unit. She's been acutely admitted. She's critically ill with profound lung disease and profound microcoagulopathies. Because of her sickle cell disease. She's very critical. And the sister says to him, this is causing me too much stress. It's exacerbating my sickle cell disease. Go to the ER and get checked out. Now, he's had an EKG before, never had any further testing, hasn't needed it apparently, including hasn't had a stress test, hasn't had a cath, hasn't had a coronary CT. Apparently, he hasn't needed it. Okay. Now, I'm going to just add here, I didn't have time to pull that data in, but really, really important. From my point of view, looking at this patient, the patient has a very long history. He's had at least 10 admissions to the emergency department, but mostly related to hyperglycemia and some secondary things, flu, virus, etc. Nothing with chest pain before, but very significant hyperglycemia without ketosis. Okay, now, the reason I want you to remember that is, first of all, he's known to the ECC. He's come there a lot. He was there like a month ago with profound hyperglycemia after a flu, probably got placed on IV insulin, got his glucose under control, basically was in mild to moderate hyperglycemia, 300 to 800, not really HHS and not ketosis. So we already have a history. We already kind of know the guy. I don't know what people knew about him, what their relationship was with him, but it is really important to remember that a lot of times when patients come to us, especially if we've had experience with them before, sometimes we can have a little bit of a preconceived notion. I'm not saying that's true here, but I want to be sure that we take a good look at how our patient is presenting. So again, I want to remind you, first thing is you look at with your patient is you say, patient history. Okay, if you had been having chest discomfort for the past 2 hours, or even the past 6 hours, with radiation to your jaw, with radiation down your left arm, with this pulling across your chest, I'd be paying a lot more attention. I'm still paying attention to you. You've got acute chest pain, but I'm not thinking this is a STEMI because you've had this pain on and off for 2 weeks. That doesn't typically happen. Typically, my friends, typically happen with a STEMI. So X for the patient history. The next step would be presentation. Does it look like a STEMI? Okay, so this is his first EKG, and I think always really important for us whenever we look at an EKG, remember, we're going to look for certain aspects, right? First, if we can, we're going to look at your axis, and that means you're primarily upright in 1, primarily upright in F. That is not so for this patient. He is actually a little upright and a little downwards. I would call that equiphasic, and very upright in F. That means his current is shifting towards the foot, and we're going to consider this to be a right axis deviation. Now, my purpose here today is not to teach 12-lead EKG, so hang tight with me. He has a right axis deviation, okay? I'm going to look globally. I'm going to go over to the chest leads, and I'm going to say, do I have an upright, a number 1 upright, downwards, and a second upright in V1? That would indicate a right bundle branch block, a very common cause of right axis deviation. He does not have that, but he does have an acute right axis deviation. So one of the first things I'm going to think about looking at this EKG is it possible if the patient has a pulmonary embolism? Another thing that's really important with PE, there's a lot of things we look at on EKG for PE, but we also look at a coving of the PR interval, which you actually see here. And normally I would look at lead 2 and V1, looking for that coving. It's not really present in V1, but I've got a little cove of the PR segment here, and I have it in lead 3. I have it in some of the chest leads as well. So I'm now kind of increasing my concern that he might have a PE. I'm going to be thinking about that in the way that I'm going to evaluate and what I'm going to rule out for the patient. Does he have a PE? Okay. Second thing I'm going to look at is, does his QRS, either on the right side, V1 representing the right or V6 representing the left, does it take longer than normal for depolarization? Both your ventricles should depolarize in less than 0.10 seconds. That's 2.5 boxes. Okay. And indeed, he depolarizes in less than 2.5 boxes. So I'm ruling out bundle branch block. So now I'm saying, okay, he's got a right axis deviation. He does not have a right bundle branch block. He does not have a left bundle branch block. But the last thing I'm going to look at is a deep S wave in the right side lead, V1, V2, V3. Got a really big S in V2. It's 5, 10, 15, about 20 millimeters, 2 millivolts. And a really tall R wave here in V5 and V6. So I'm going to take the biggest one, 5, 10, 15, and 20. 20 plus 20 is 40. And the primary current is not going to the right. If it was going to the right side of the leads would be upright. It's not. The primary current is going to the left. That's why the left-sided leads are upright, and they have a lot of voltage. So immediately I'm also going to say, okay, my patient has a right axis. He does not have a right bundle branch. He does not have a left bundle branch. He does have LVH. Now, I myself, I would be done with that in less than 5 seconds, right? I'm walking through the process. Now I'm going to step back from the EKG and I'm going to say, which I would probably say first, do I have acute ST segment elevation in at least 2 leads of a lead group? So I'm going to look at 1, AVL, V5, and V6, and the answer is no. I'm going to look at 2, 3, and AVF, and the answer is no. But oddly enough, I do have some ST segment depression. If I have ST segment depression as the reciprocal, the opposite leads, which would be the lateral leads, would have ST segment elevation. So I've got ST segment depression, but it's not as a reciprocal change to a STEMI. Does that mean that it's possible this is a non-STEMI? And of course, that'll be the next thing I think. I'm going to rule out for PE. I'm going to rule out for non-STEMI. I'm going to look over here at his chest leads. He does have some ST segment elevation here in V2, a little bit in V1, but often you'll see ST segment elevation, V1, V2, and sometimes into V3 when you have LVH. So that's going to make this really muddy for me. I'm pretty good at evaluating EKGs, but for me, I would still refer this to a cardiologist, and I would do it now. No, I'm not really going to wait, because you've got acute chest pain and you've got a strange looking EKG, and I'm not really clear that I can, even if I'm a great ECC attending or a great MICU attending or a great trauma surgeon or anybody who's not a cardiologist, I'm not sure that I have the capacity to actually rule in or rule out anything that's occurring for this patient. He has some significant abnormalities. First and foremost, he does have ST segment elevation. That could be from LVH, but he has T-wave inversion. And you can see here in V2, in V3, in V4, and V5, he has T-wave inversion. Now, sometimes you're going to have T-wave inversion with ventricular hypertrophy, but typically the T-wave inversion will be in the leads where we've identified the most hypertrophy. So you would expect that possibility in V4, V5, and V6, but not necessarily in the right-sided leads. So from my point of view, I'm going to be honest with you. From my point of view, when I looked at this EKG, I said, I really don't see any clear signs of patients having a STEMI. Lo and behold, what I discovered from the chart, what I'm going to share with you, which we learned together, which is really awesome. Okay, so just going by what we know right now, X for the patient history, not really. And not so much on terms of the presentation. Really doesn't look like a STEMI. Don't have ST elevation, ST depression in opposite walls. I have some EKG changes that are kind of bizarre. I've got LVH, that kind of muddies up the picture. I'm a great ECC attending. I've been attending for 10 years. I'm really smart. I love to look at EKGs, but I am still above my depth. Or below my depth, or I don't know, above my depth. I'm not sure. I guess we could refer to the submarine and say it's really deep and it's way too deep for me. So that's really what I'm saying here. And I have not yet shown you the troponin. So really, really important. I want to remind you about high sensitivity troponin. It's 1,000 times your normal troponin because of the way that it is measured. So it gives us much higher precision at much lower concentration levels. I got on an elevator about 9 months ago when we made the transition high sensitivity troponin with an incredible nephro intensivist who said to me, why are we looking at high sensitivity troponin? What does it mean? He's not a cardiologist. He said, what does it mean? I guess he thought I would know, and he was right because I was teaching people about it. I said, it's actually just your basic troponin times 1,000 because we're looking at it in liter rather than in milliliters. And so we're looking at a different concentration gradient, and that's all it is. And it helps us to identify people who are at that lower threshold that you were missing when you were just looking at point of care troponin 0.04. So that's it. And we just must knows for this troponin is, again, women less than 15, men less than 10. anything at 20, anything higher than that indicates injury, but it may not be acute injury. Acute injury means that you continue to go up. And that's why you have to do a second troponin. And by the way, it has to be drawn 60 minutes after the first one, not 60 minutes after the first one results, 60 minutes after the first one was drawn. And we have to be really, really rigorous about this because it really identifies patients early on who are at significant risk. Okay, so here is our first lab report. We're looking at in our patients. So first and foremost, his sodium is 130. What that means to me frequently when I'm looking at a patient like this, the things that go through my head when I see a low sodium, 130, is are they hyponatremic and hypervolemic, meaning you have volume overload, maybe from heart failure, maybe from kidney disease. And so my first concern is always that what I want to look at here is in relationship to your osmolality. So your osm is normal, 280 to 300 is considered normal osm, and that's the goal of the concentration of particle to the fluid. So your osm is normal. So what that means to me is that this is hyponatremic, euvolemic. This is what I'm thinking, hyponatremic and euvolemic. I'm not really sure what relevance this has in the end result of this patient, but I'm tucking that away in my mind. I'm really concerned about it. He has a normal osm, but he has a low sodium. Okay. Now I'm going to progress through here. I'm going to see that his chloride is a little bit low. I'm not worried about that. His total serum CO2, which is a reflection of bicarb, is perfect. Normal serum CO2 or normal bicarb, the range is 22 to 26. 24 is perfect. Woohoo! He doesn't have any acidosis. That gives me a lot of relief, or I don't think he has acidosis. Gives me a lot of relief. And I'm going to combine that with my anion gap, and my anion gap should be 12 plus or minus 2. So your gap is 10. That's 12 minus 2. You got a normal gap. Got a normal CO2. You got a normal gap. You don't have acidosis. I don't need a blood gas. Don't let me not get going down some bunny hole there. I don't need a blood gas. My patient does not have metabolic acidosis. He looks like he has normal metabolism right now, except for one thing. His glucose is 511. Now, I'm going to remind you if you work in the ECC, you work in the ICU, I don't really care where you work. Hyperglycemia, always remember, hyperglycemia in the serum means relative hypoglycemia in the majority of your cells, except in your myocardial cells, your cerebral cells, and your hemopoietic cells. So all this excess glucose is getting delivered to the myocardium. We have some concerns about what's happening to the patient. And we cannot ever allow acute chest pain patients to be hyperglycemic. He needs to go on an insulin drip, and he needs that right now. So I know how busy you are, but to protect his myocardium, he needs to go on an insulin drip right now. That doesn't happen because there's so much else going on with the patient. It takes a long time before his glucose gets even initiated under control, not until he gets to the CVICU. So he spends a fair amount of time in the ECC with severe hyperglycemia, goes to cath lab, he's hyperglycemic, he gets to the cardiovascular intensive care unit, and by that time, they get his glucose under control. I think we can do a better job worldwide. I think we can do a better job, and we should do a better job of managing glucose, particularly in patients who have cardiac deficiency. Okay. All right. So then I'm going to go down from here. I'll look at his BUN, which is 26, and his creatinine is 1.8. They did not calculate here a BUN creatinine ratio, but that would be 26 divided by 1.8. It's just telling you that this is actually telling you that you have an relative equilibration between failure to excrete urea and failure to excrete creatinine. So both those numbers are going up in proportion to each other, which typically means that I may have some significant pre-renal cause. In our case, what we're going to believe is that it's probably because of his acute chest pain, that it might be that he has some cardiac involvement. Remember, he's a diabetic. He's a long-term diabetic. He has hypertension. He has positive HIV. He's got a lot of other things that muddy up his picture. But I want to remind you, GFR should always be above 80. If we get to 60, we're really concerned, and below 60 is a profound alteration. So he is really at significant risk for acute kidney injury, and he has diabetes and hypertension, other things that are putting him at risk. Okay. So all really, really important for us when we're looking at this patient's laboratory sign, like, what the heck, man? Has he got AKI? Has he got AKI on chronic kidney disease? I have no reference anywhere in his chart that he has known chronic kidney disease. So this really looks like an acute kidney injury event. But again, he has long-term diabetes, so I'm not guaranteeing that he didn't actually have chronic kidney dysfunction that was evolving over time over the last 5 or 10 years. And he has profound hyperglycemia. So the question always is ketosis, yes or no. And by the way, we don't actually determine if you have ketosis by looking at serum ketones in the blood or urine ketones. We determine whether or not you have ketosis by your anion gap, and your anion gap is 10. So we would expect if you have ketosis that you would have an anion gap of 14 to greater than 20. You've got to have a wide gap, which is the balance of negative and positively charged particles measured in the blood, to actually tell us whether we think you have ketosis. That's what we treat when we're treating patients at the bedside. We're not looking at urine ketones and serum ketones. You might do them. They're not defining whether or not the patient's in ketosis. They take a long time to accumulate and a long time to clear. So they're not real-time right now data. The real-time right now data is anion gap. Patient's got a normal gap. So I don't think he has ketosis. I do think he has a beginning of AKI. I'm pretty worried about the guy. Don't think he looks too good. And then I get this. Okay. So here's what I get, right? Liver enzyme, troponin, which normally should be less than 20, is 9,470. Okay. Now he gets this is HS troponin. I didn't see the point of care troponin. I'm sure it was done. I just didn't see it anywhere. His second HS troponin, which is about 90 minutes after the first one. So remember, we're going to try to do it at an hour. 90 minutes later is 11,500. So remember, I'm looking for a delta change of 5. I've got a delta change of 2,000. This is an acute event. Okay, so now I'm armed with this information, which is, hopefully, patient history, presentation on EKG, not so much. No reciprocal changes that I can correlate by, first troponin, second troponin, really elevated with a big delta. Okay, so now I'm going to start focusing on that. I've got something really acute. Doesn't mean that it's a STEMI, but I've got something that's really acute that's happening to this patient. Now I've really got to focus on that. And I've got to come back to the patient. His vital signs are still stable. He's on and off. He's kind of having chest pressure. One thing for sure is if you are able, my friends, if you are able, if you have an EKG machine, you know how to do an EKG, you know how to load it, you know how to send it to your cardiologist. If you don't, you've got to grab an EKG tech. But if you're able, when a patient is telling you that he's having chest pain or chest pressure or the chest pulling, you want to do an EKG during that time, if possible. It's very hard to do in RED. We're saying that our EKG techs do an average of 400 EKGs per day. Sometimes there's only one EKG, that's for the hospital, but there's only one EKG tech in the ER, and we've got lots of patients who have to be screened and get EKGs. So it can be impossible. Every nurse should learn how to do an EKG and how to load it. We should all know how to do that, because the thing is, I'm not really trying to do someone else's job. I'm trying to do what's right for my patient. And if you've got 300 other patients you have to look at, I have 2. I have 4, I have 6. I'm doing the EKG on this patient if he's got chest pressure. So I really want to encourage everybody to actually work hard to have an EKG machine in your area, to learn how to use it, learn how to load it, learn how to communicate it to your cardiologist. So just doing the EKG is not enough. You've got to be able to electronically load it and communicate it. So you've got somebody who's got your back who's looking at that EKG. Okay, now here's his second EKG. Okay, so you might look at this and say, it doesn't really look that much different than before. Now I'm primarily upright here in lead 1. That's probably lead placement. Got a big upright in AVF, but maybe I don't really have a right axis deviation. The other time, maybe it was lead placement. Okay, still got LVH. Still don't have a bundle branch block because I'm not wide. The other thing we look at when we look at EKG is what we call R-wave progression. assuming either a smaller or no R in V1, a little bigger in V2, bigger yet in V3, bigger in V4, big in V5, and a little smaller in V6. That's what we call normal R wave progression. Your patient has poor R wave progression. So that's also a really important signal here. We've got these little T wave inversions. We have this almost what we would call a biphasic T wave, where it's above and then it goes below, and very significant. Have a little in V2, but it's very significant in V3, V4, and V5. So still, I'm the attending, I'm the bedside nurse, I'm the EKG technician, I'm looking at this, I'm saying, this is just not a very expressive EKG. I want it to express that the patient is having an acute process because this troponin expresses that, but I'm not seeing it in the EKG, okay? And I'm really trying to find something in the EKG that's going to be meaningful to me. But even the coving of the PR segment looks better now. And remember, that coving usually represents, that's that little downward, kind of just a little cove of the PR segment, can indicate pericardial effusion. It can indicate pulmonary embolism. So we're going to use that. And what he looked like before, I was like thinking, oh, maybe this might be a PE. There, we've got some other issues. And is this just a non-STEMI with diffuse changes? I'm not really too sure, except for one thing. That troponin level for a non-STEMI, a troponin jump like that, that's an emergent event. So whether it's a STEMI or a non-STEMI, with that acute troponin jump, you need to get cardiology on board and you need to do it really, really quickly. So again, we're not, in the book of Michael McDaniel, who's the chief of cardiology here and the chief of cardiovascular services and the chief of interventional cardiology, he says, I want patients to meet all three, but I love him and he breaks every rule that he makes. So he never requires the patients have all three. We want our patients to have all three, but a lot of times they're not going to have all three. I'm really focused right now on that troponin. I'm concerned that we've had such a significant jump in the troponin over time. Okay, excuse me 1 minute, just be sure this is not critical. Hi, this is Barbara. Hello? Hello, not critical, because they didn't answer. Just because I had that patient with the PA catheter in the wrong position. So sorry, I normally don't even answer, and I'm going to turn my phone off. Okay, all right, my friends. So just remembering those signs that point to STEMI for us: significant ST elevation in contiguous leads, 2 leads of a lead group, reciprocal changes on the opposite wall of the heart. And those changes really have to occur in leads that go together. That's what we call the contiguous leads, okay? And the other thing that I've already mentioned, when you evaluate your EKG, these are Barbara's 4 simple rules, right? So the 5th rule would be always look for ST segment elevation. That's not in here. You're looking for normal electrical direction. So primarily down in V1 and upright in V6, that's normal direction. Normal voltage, less than 10 millimeters or 1 millivolt downwards in V1, less than 10 millimeters or 1 millivolt upwards in V6. And that will go for all the right side of V1, 2, 3, right side, V4, 5, and 6, left sided leads. And that the length of time it takes for ventricular depolarization should actually be less than 0.10. I'm okay if it goes up to 0.12. Anything wider than 0.12, I'm going to be concerned about. And then I also look for that R wave progression. So, and of course, in addition to that, I'm always going to look for ST segment elevation, right? So elevation, I've tried to color code this to say, okay, 1 and L are acute upper lateral, 2, 3, and AVF are inferior. AVR is representative of right-sided changes, and there are some real significant things that can happen to that AVR lead that we should pay attention to. V1 and V2 are anteroseptal, V3 and V4 are anterior, V5 and V6 are anterolateral. And so these are the leads that are looking directly at that area, V1 and 2, the anteroseptum, V3 to 4, the apex, V5 to 6, the anterior lateral. And these are the opposite leads, okay? Those are the reciprocal leads. So we always want to have that in our mind. We also want to remember that your expectation is you'll either have a tiny or no R wave in V1, and it will get significantly bigger, like going up to a staircase. Usually doesn't get any bigger after V5. It stays the same, or it might get a little smaller in V6. That's known as R wave progression. So all those things, right? Looking at normal direction, normal width, normal height or depth, and R wave progression and ST segment elevation. We should practice this. It means whatever you learn from me and you learn from other people, and you've learned a lot from 12-lead EKG and you're studying it, you're reading about it, you have to apply it every single day that you're at work. You got to look at a bunch of EKGs, because otherwise you never get better. And we're going to make a lot of wrong assumptions when we look at EKGs, and that's okay too. That's all right. That's part of learning, right? So we're looking for that beautiful R wave progression. Okay. Now here's my first note. My first note from my nurse, 611 2300. Patient is alert and oriented times 4, ABCs intact, no acute distress, respiratory rate even, unlabored, vital signs stable, denies pain, bed is in the lowest locked position, side rails up, cold lights within reach. I adore how we document. It's like, okay, JCH, 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 but I don't really get much information about the story. Okay, I don't get that much information about the story. Now, what happens next? The next note is not until 2 a.m. Okay, and in 2 a.m., sort of the same kind of thing. All the JCH things, you know, your bed rails are up, your wheels are locked, your bed at the lowest position. Patient doesn't have a fall risk. He's on the monitor. He's getting just now at 2 a.m. just now placed on the cardiac monitor. Okay. He's on non-invasive blood pressure and SpO2 monitoring just now. I don't think so. I think that happened earlier, but it wasn't documented. This nurse documents it now. But I'm still going to say, when I'm looking at these notes, I'm interpreting. We're not too worried about this patient. Yeah, he's had chest pain for 2 weeks. Doesn't really have ST segment changes. Yeah, he's got a really significant acute troponin elevation and a significant delta between his first and second troponin. I'm still not that worried, right? Because if I'm the nurse and I'm worried, I'm going to write cardiology has been notified. Cardiology has looked at the EKG. Cardiology is coming. My attending feels comfortable with how this patient looks right now. At this point in time, we are not providing any therapy. We're just monitoring the patient. I want a story. I want a story. I want a story I can follow, because there were things that were happening, and I think everybody was giving him really excellent care, but I can't really tell that from looking at the notes. Okay. So cardiology comes in, it's 3 a.m. 3 a.m. the cardiology resident comes and he says, hey, this patient is having a STEMI. Really? Why do you say he's having a STEMI? His EKG never changed. This is a very particular type of STEMI presentation, and it's called a Wellens STEMI. And actually, you may see it relatively significantly in your patient population. It is all determined by the patient's T waves and by his troponin bump. So the fact that he had, I am not telling you because I'm going to tell you, I'm very hip to Brugada syndrome. I'm very hip to AVR. The AVR lead, ST segment elevation as being indicators of severe disease and actually life-threatening disorder. I wasn't really familiar with Wellens changes on the EKG. I'm embarrassed to tell you, but look, we're all learning together. How fantastic. And I love cardiology. So I'm actually disappointed myself that I couldn't look at that and say, oh, this is late presenting STEMI with Wellens T-weave changes on EKG. I didn't do that. The medical attendings in the emergency department didn't do that. When cardiology came, and it was probably really related to this particular, it wasn't a resident, it was a fellow, this particular cardiology fellow, so pretty high up the cardiology chain, who says, hey, we got to get to the cath lab right now. This patient's got Wellens T-wave changes on EKG. And most importantly, the patient has a significant profound troponin bump. This is really acute. Now, what I would tell you is when you have a troponin bump like that, you've got to get on board with cardiology to say, I'm worried about the troponin bump. Now, your patient may have come in with a troponin of 30,000, but if his second troponin is 28,000 or 29,000 or 30,000 again, he's not continuing his process. We're going to correlate that to not be necessarily acute. This was an acute bump, and this probably should have spearheaded a much more rapid evolution, because we got both of these were back by 12 midnight. It's now 3 a.m. He's got Wellens T-wave changes, and we're going to look at what those are. So right away, got to go to the cath lab right now. And he gets loaded with ticagrelor and aspirin, and he goes to the cath lab. And in the cath lab, my friends, 100% LAD. Okay, 100% LAD. So and it was proximal. So that means closer to the bifurcation of the left main into the left anterior and the left circumflex. So honestly, even though there was a little bit of a delay, it was really literally about 5 hours. So there was a little bit of a delay, but we were able to restore his myocardium. He was discharged home the next evening on the 13th. He did not actually lose significant myocardium. He did not present with heart failure, so fantastic. But it would have been nice to have identified him a little bit earlier. And mostly, I think it would be related to that troponin bump, because everybody is not going to understand this Wellens T-wave changes on EKG. He also had pretty significant disease in other vessels, the distal LAD and his diagonal, D1 is his diagonal, but he had nice normal left ventricular function. Thank goodness we identified him, we intervened, we gave him a therapeutic intervention that protected him from losing his myocardium. How fantastic, and great job done by all. Okay, so what is Wellens syndrome? Okay, so right here, what you're seeing is a point to this lesion. Okay, and that lesion is in the LAD, and this is a pretty significant lesion, which is an occlusion to the blood flow, right? And typically how this presents is T-wave abnormality in V2, V3, and possibly V4. And you often will see this during your pain-free period. During pain, you may see some ST segment changes, but here, when you're in the pain-free period, how you're identifying this is by T-wave abnormalities. And that's usually seen, as I say, during a pain-free period of time. STs are relatively normal. It is highly specific for critical, life-threatening obstruction in the LAD. So whoever made sure that cardiology took a look at this EKG, bravo, bravo, fantastic. And also, you're going to see this appear before you are actually having significant infarction. Now, remember, I'm concerned he's 9,000, he goes to 11,000, but and no more troponins were done. But I say by the time he went to the cath lab, he was probably at 30,000 troponin. He didn't get another troponin. He only got the first 2. He didn't get any more. Okay, that's fine. Okay, they have a very high risk because of this LAD. They have a very high risk of anterior or inferior myocardial infarction and death, and 75% risk of death within the first week. Medical management doesn't work. Ticagrelor, aspirin, Plavix, heparin, nitroglycerin, if you were doing that, morphine, oxygen, medical therapy doesn't work. You have to go to the cath lab for this critical obstruction. Okay, so I always like to say again for the cheapsies, this beautiful visual that just reminds us Wellens syndrome is characterized by biphasic, which means up and then down, or deeply inverted T waves in V2, V3, and occasionally in V4, plus a history of recent chest pain. Okay, so my patient's been having chest pain, it comes and goes. I don't think that's important. I look at the EKG and I see this biphasic T wave. Again, I'm not asking everybody to be a cardiologist. I'm saying pay attention to all 4 criteria. And if you meet one of them, like that troponin, you should alert somebody who has higher level of cardiac knowledge and higher level of EKG knowledge. It is this Wellens syndrome, highly specific for critical stenosis of the left anterior descending coronary artery. So we look at this patient, you see you have a little T-wave inversion here. You have a deep inversion V2, V3, and also in V4. This is not our patient. But when we look at our patient, what we see is that biphasic deep inversion in V3 and V4, combined with intermittent chest pain. Don't know if his EKGs were done during his chest pain or his pain-free periods. That's going to be really important because during those periods, I'm not going to expect to see ST segment elevation. And I can't really explain the elevation I'm seeing here and say that is ST segment elevation or it's not ST segment elevation. Okay, so again, Wellens syndrome, inverted biphasic T waves in the mid-precordial leads, V2, V3, V4. I see that during pain-free period. So what that means is I'm asking my tech to do an EKG during the pain-free time. I'm calling the tech back, or I myself am going to do an EKG while you're having pain. Okay, sometimes you you may not actually see an elevation in troponin. That's why this elevation in troponin was so significant, because you may not have lysed your myocardial cells, at least early on. You will eventually, but at least early on, you may not have done that. Okay, now, again, this is a critical occlusion in the proximal LAD. That means close to the bifurcation. So left main splits into the LAD and the circumflex, and this is a proximal lesion that's close to that split, which means it actually covers a very, very large surface area of the anterior and some of the inferior wall, mostly really the anterior wall. And we all know that when you have a big anterior MI, you typically convert into heart failure. And now you have a reduced EF and you're trying to cope and live with heart failure. So this was pretty important. So again, this is kind of this same, basically copied from the fantastic article that just reminds us about Wellens syndrome, right? The deeply inverted or biphasic T's, EKG pattern present only in the pain-free state. That's the only time we're really going to see that. Isoelectric or very mildly, minimally elevated ST segment. Remember, it's in the chest leads. So 1 millimeter, I'm not so worried about in the chest leads, right? I don't have Q waves, and I may have preserved R wave progression, meaning I may have R waves that get a little bit bigger. But the patient always has a recent history of chest discomfort or angina, and they may have normal or slightly elevated cardiac markers. Now, remember, our patient was quite elevated because his process has been going on for 2 weeks. He's having this intermittent disruption, okay? And I loved this understanding the T wave changes. This is what is thought to occur, okay? So you have a sudden complete occlusion of the LAD while you're having pain. You will probably have a transient anterior ST segment elevation, but you have to capture it on EKG during pain time. But then the patient maybe took some aspirin, they had some spontaneous reperfusion, and so they kind of reperfuse the LAD, the chest pain goes away, ST segment improves, but the T wave becomes biphasic or inverted, because that was the secondary event that happened after you had acute occlusion of the LAD. So very, very important to us. It's very similar to what we see after we do PCI. We'll always see a biphasic or a fully inverted T wave as the patient reperfuses his myocardium. Now, over time, if he does not re-occlude his artery, T waves will just present normally like they would with the non-STEMI, become deeply inverted, return to normal, etc. But if the coronary perfusion is unstable, and by the way, in this patient, we're assuming he was unstable because he kept having chest pain on and off for 2 weeks, the LAD continuously reoccludes, okay? So sometimes what can happen is during your pain time, your T waves may no longer be biphasic because they're on their way to becoming hyperacute. So they switch from being biphasic or inverted to being hyperacute. That's a hyperacute STEMI. And usually that's going to occur with chest pain. So if I'm doing an EKG during your chest pain time, you might have ST segment elevation. Your T waves will shift from being inverted to being horizontal to being hyperacute. And that's called a stuttering pattern. And the thing about Wellens syndrome is it's an occlusion that doesn't necessarily stay. So you occlude, you reperfuse, you reocclude, you reperfuse, you reocclude, you reperfuse. Sometimes people can confuse it with coronary artery spasming, which is very similar. Spasm and occlude, dilate, unocclude. Spasm and occlude, dilate, unocclude. That's vasospastic coronary disease, often seen with particularly with patients who are abusing cocaine, patients who have inflammatory response like asthma to cold, they can have vasospastic activity. But here in Wellens syndrome, it's an actual obstruction. Okay, so I am telling you, I'm not necessarily saying any of us are going to diagnose this, but I want to make sure that we remember, although we have 4 criteria to really say that we have a patient who has a STEMI. When we have a patient who gives a presentation similar to this, with such an acute change in his high sensitivity troponin, we want to get cardiology involved. When we look at that, when we look at an EKG and we say, this EKG is not normal, but I don't know why it's not normal, I'm not really clear why it's not normal, but my troponin is elevated. My patient has kind of a poor historic presentation, but he has an acute rise in his troponin and he has an EKG that doesn't look normal. I want to make sure that I identify that cardiology needs to be called. He had a drug-eluting stent ×1. He had beautiful reperfusion. His post-cath visualization was fantastic. I was trying to load it, but I was having a little trouble. But remember, he was discharged home from our cardiovascular intensive care unit because his care was so good. And I'm going to completely relay that to, I do believe, even though it wasn't really that well identified, that the ECC doctors actually said something's wrong, but we don't know what. Well, let's get cardiology to take a look at the patient. Now, when we review the patient, we have a weekly STEMI meeting. And when we reviewed the patient in our STEMI meeting, the discussion was, oh, he was 5 hours without being evaluated. But I'm saying when I'm looking at all this and I'm looking at his EKGs and I'm looking at his presentation, I think 5 hours was pretty darn good. Would we be happier if it was shorter? Yes. And by the way, I would always be happier if I see somebody who has hyperglycemia with cardiac dysfunction. I'm always happier if they're on continuous IV insulin. I want their glucose brought into normal range to protect their myocardium. So that's today's talk. We're ending at 5 minutes to 5. That's almost a record. We hardly ever end before 5. I want to thank you so much for joining today. I'm certainly happy to have any discussion, but I am going to end this recording. I'm going to hopefully see you next week and the weeks beyond for Tuesday topics and wonderful Wednesday. Thank you so very much. I really appreciate it.